Respected Chairperson, panelists, speakers, learned audiences, Assalamu alaikum, good evening. It's a pleasure to welcome you in our today's webinar on small vessel vasculitis. Bangladesh Rheumatology Society has been organizing this monthly webinar regularly since December 2020. And this is our 30th program. And today we have two young rheumatologists as speakers. And you know, in each program, we try to invite one overseas expert rheumatologist. Today, I am very happy to have Professor Aman Sharma, an evergreen, very polite gentleman with us. His bio sketch is full with so many successes. He is now executive editor of Indian Journal of Rheumatology. He is the founder of Indian Vasculitis Registry and Relapsing Polychondritis Registry. He was a member of the annual meeting planning committee ACR 2015 to 2018 and an expert reviewer of ACR APLAR classification criteria of Gpa, Mpa, EGPA, and Takayasu arteritis. He is an author of several books like Textbook of Systemic Vasculitis, Psoriatic Arthritis, Spondyloarthritis, Tropical Rheumatology, Urgencies and Emergencies in Rheumatology. He has published 425 scientific papers and 56 book chapters. Long story short, he has so many achievements. A very warm welcome, Professor Aman Sharma, in our today's session. Now, with the permission of the chair, I would like to request our moderator of this webinar, Dr. Shahin Mahmood, to conduct this scientific session. Dr. Shahin Mahmood, please.
Thank you very much, Professor Minhaj sir, to give me the privilege of this webinar. I'm Dr. Shahin Mahmood, working as a rheumatologist in the National Institute of Neurosciences, which is situated in Agargaon, Dhaka. I welcome you all to today's webinar, and with the due permission with the chairperson, I am going to the program. We know today's webinar, chairperson of today's webinar is Professor Syed Atiqul sir, President of Bangladesh Rheumatology Society and immediate past President of APLAR, and he was also the founder chairman of the BSMMU in Rheumatology Department. And we have the panel of experts, Professor Minhaj Rahim Choudhury sir. He has the venous stroke. The venous stroke, when you suspect, when you do a CT. He is the chairman, Department of Rheumatology, Bangladesh Sheikh Mujib Medical University, and also the Secretary General, Bangladesh Rheumatology Society. And already we have heard the overseas experts, our guest experts, Professor Dr. Aman Sharma. He is the Professor, Clinical Immunology and Rheumatology, Internal Medicine, a Postgraduate Institute of Medical Education and Research, PGIMER, India. And we have also the Professor Dr. Muhammad Nazrul Islam sir, Professor Department of Rheumatology, BSMMU, and Secretary General APLAR. And we have the Professor Dr. Muhammad Abu Shahin, Professor Department of Rheumatology, BSMMU, and we have the Dr. Shamim Ahmed, Associate Professor, Department of Rheumatology, BSMMU, and we have the Major Dr. Syed Jamil Abdal sir, Consultant Rheumatologist and Medical Medicine Specialist, Green Life Center for Rheumatic Care and Research, Dhaka. And for this webinar, we have two speakers. We'll present our today's webinar. And first speakers is the Dr. Tania Kobir, Medical Officer, Bangladesh Secretariat Clinic. Today's topic is the small vessel vasculitis. And for the audience, I would like to say, if you have any question, please you will drop the question, your question in the question answer session drop box or in the comment section. After the both presentation, we will take the question and answer sessions. And today's webinar is media partner Doctors TV and scientific partner ACI. So I'd like to request to Dr. Tania Kobil to present her section, and her section is the small vessels vasculitis, mainly focuses on the ANCA-associated vasculitis. Dr. Tania Kobil.
Thank you, Dr. Shahin. I think I am audible.
Yeah, audible. You are audible.
The host have to able to allow me to present my screen. The host has disabled the participant screen sharing. Is it visible?
Yes, it is visible.
Visible.
Thank you. Good evening. I'm Dr. Tania Kobil. For next 20 minutes, I'm going to talk about small vessel vasculitis, mainly focusing on the ANCA-associated vasculitis. I would like to express my sincere gratitude to the Bangladesh Rheumatology Society for giving me the opportunity to present in front of such a learned audience. The vasculitis are defined by the presence of inflammatory leukocytes in vessels with reactive damage to mural structures, which causes bleeding and compromise of the lumen of the vessels, which results in tissue ischemia and necrosis. Vasculitis may occur as a primary process or may be secondary to another underlying disease. The exact pathogenic mechanism underlying disease is still unknown. The vessels are classified into large, medium, and small blood vessels according to their diameter. The aorta and its main branches are the large vessels with diameter is more than 10 millimeter. The medium vessels include the vessels with muscular walls in deep dermis and subcutis, mainly the main visceral arteries and veins and its initial branches. The small blood vessels include capillaries, post-capillary venules, and non-muscular arterioles. Typically, the diameter is less than 50 micrometer. This picture is showing the 2012 revised Chapel Hill consensus classification of primary vasculitis, where the large vessel vasculitis include Takayasu-arteritis, the medium vessel vasculitis include polyarteritis nodosa and Kawasaki disease. The small vessel vasculitis include ANCA-associated vasculitis and immunocomplex small vessel vasculitis. The ANCA-associated vasculitis include microscopic polyangiitis, granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, and immune complex small vessel vasculitis include paraglobulemic vasculitis, IgA vasculitis, hypercomplementemic articular vasculitis, also known as anti-C1q vasculitis, GBM disease. This table is showing the typical clinical manifestation of large, medium, and small vessels vasculitis. The small vessel vasculitis typically present with purpura, physicobulous lesions, urticaria, glomerulonephritis, alveolar hemorrhage, cutaneous extravascular necrotizing granulomas, sphincter hemorrhage, uveitis, episcleritis, and scleritis. Now, a few words about ANCA. The ANCA stands for the anti-neutrophil cytoplasmic autoantibody. Two types of ANCA assays are widely used: the indirect immunofluorescence assay and the enzyme-linked immunosorbent assay, which is the ELISA. The immunofluorescence assay is more sensitive and ELISA is more specific. The optimal, there is controversy about the detection of the ANCA by the methods. Some stands for performing both the immunofluorescence and ELISA, but some stands for performing the ELISA, as these are more specific. In vasculitis, there are two target antigens which are relevant. These are leukocyte proteinase 3, PR3, and myeloperoxidase. This in short is known as MPO. These are located in the cytoplasmic azurophilic granules of neutrophils and peroxidase positive lysozymes of monocytes. The antibodies with target specificities for PR3 and MPO are called PR3 ANCA and MPO ANCA respectively. This is the immunofluorescence. The two major immunofluorescence patterns are found. Cytoplasmic ANCA, which is where the staining is diffused throughout the cytoplasm, and in most cases, antibodies are directed against the PR3. And the perinuclear ANCA, where the staining pattern is around the nucleus, and usually these are directed against the MPO. The ANCA-associated disease, not only the vasculitis, but other diseases are associated with ANCA, like anti-GBM autoantibody disease. At 10 to 50% of the cases, the ANCA is found at the time of diagnosis. Usually, the ANCA is directed against MPO rather than PR3. There is a list of drugs which can cause drug-induced ANCA-associated vasculitis. The most common drugs, commonly used drugs are propylthiouracil, carbimazole, hydralazine, cocaine, levimazole, minocycline, clozapine, phenytoin, rifampicin, isoniazid. Patients mostly present with constitutional symptoms, arthralgia or arthritis, cutaneous vasculitis. Mostly they are MPO ANCA positive. In hydrazine-induced ANCA-associated vasculitis, patients frequently present with kidney involvement, usually autoimmune glomerulonephritis, where the withdrawal of hydralazine is not enough. They require immunosuppressive therapy. The list of non-vasculitis rheumatic diseases where ANCA is probably found. These are like rheumatoid arthritis, systemic lupus erythematosus, Sjogren's syndrome, reactive arthritis, systemic sclerosis, and phospholipid syndrome. Some GI diseases like ulcerative colitis, primary sclerosing colitis, cholangitis. In cystic fibrosis, non-MPO PANCA are found. There is a strong association with Pseudomonas aeruginosa infection and colonization. C-ANCA and PR3 ANCA positive is found in subacute bacterial endocarditis. ANCA is also reported in tuberculosis, leprosy, acute infectious mononucleosis, aspergillosis. De novo ANCA-associated vasculitis has been reported in COVID-19 as well as following administration of COVID-19 mRNA vaccines. Now, ANCA-associated vasculitis. ANCA-associated vasculitis is a necrotizing vasculitis primarily affecting small to medium-sized vessels. These three clinical pathology conditions are includes these included in ANCA-associated vasculitis. These are granulomatosis polyangiitis, macroscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis. The men and women from a wide age spectrum and diverse racial backgrounds. This picture is showing the global epidemiology of the Gpa and Mpa, where you can see the Gpa is more common in European and American countries, and Mpa is more common in East Asian countries like Japan and China. Recently, a large cohort of GPA from North India demonstrated that the greater proportion of PR3 ANCA are found than MPO positive MPO ANCA in ANCA-associated vasculitis patients. Including in ANCA-associated vasculitis, these are this is typically showing the comparison of the three syndromic ANCA-associated vasculitis, where we can see the prevalence is MPA is more prevalent. The typical age of onset in GPA is 45 to 65 years. In MPA, it is 55 to 75 years. In GPA, it is 38 to 54. Male-female ratio is equal in all three syndromes. And PR3 ANCA is found 65 to 75 patients of GPA. MPO ANCA is found in 55 to 65 patients of MPA, and ANCA is found negative in 55 to 65 patients of EGPA. Then recurrence rate is higher in GPA. This is simplified schematic presentation of the pathogenesis of ANCA-associated vasculitis. You can see the genetic factors, aging, infection, inflammation, and some environmental factors all play a role in inducing the loss of tolerance of T and B cell to neutrophilic PR3 and MPO, and which differentiation of the T helper cell into follicular T helper cell, which helps differentiation of activated differentiation of B cell into activated B cell, which differentiate further into plasma cell, which produces the PR3 ANCA or MPO ANCA. And the PAMP TLR, DAMP TLR, and pro-inflammatory cytokines, increased expression of PR3 or MPO all play a role in activation of neutrophil and neutrophil priming. And there's also some recent advancement like the invention of the alternative complement activation, where C5a is activated C5a is bound to C5a receptor on the cell surface of the activated neutrophil. The PR3 ANCA, the ANCA bound to the causes the monocyte activation and the activation of the activated neutrophil. The activated neutrophil causes endothelial injury by several mechanisms, like releasing of the microparticles, formation of the neutrophil extracellular tract, releasing of the reactive oxygen species, protease, and ANCA antigen itself. Now, the clinical features. All the three vasculitis share common systemic features like fever, weight loss, malaise, fatigue. ANCA-associated vasculitis are frequently misdiagnosed as infection, malignancy, depression, or osteoarthritis, especially in elderly people. This picture is showing the involvement of the organ systems in three different ANCA-associated vasculitis, where you can see the eyes, heart, muscles, and skin are more frequently involved in EGPA, and the ears and auditory system are more involved in GPA, and nose and sinus are also more involved in GPA. Lung, gastrointestinal tract, and peripheral nerve are more involved in EGPA. Patient may present with some ENT manifestations like nasal crusting, sinusitis, otitis media, earache, otorrhea, persistent rhinorrhea, polychondritis, conductive and/or sensorineural hearing loss. Patients with GPA more frequently develop bone and cartilage destruction, resulting in a sudden nose deformity, upper airway and retroabdominal mass, and cranial nerve entrapment. This CT scan of the sinus is showing there is destruction of the inferior turbinate, the partial destruction of the middle turbinate, and there is destruction of the nasal septum. This is the acute case, and in chronic case, you can see there is complete destruction of the nasal septum and new osteogenesis. The most common symptom of the lower respiratory tract are cough, hemoptysis, and pleuritic pain. The severity of the symptom and signs may vary from asymptomatic to acute and fulminant alveolar hemorrhage with respiratory failure. It is to be noted that among the patients of GPA, it is unusual for pulmonary symptoms to occur in the absence of upper respiratory tract symptoms or signs. Tracheobronchial involvement include tracheal or bronchial stenosis, mass lesions, tracheobronchial malacia, and tracheoesophageal fistula. And interstitial lung disease is commonly associated with MPA. This is a study which was conducted to find out the pulmonary involvement in ANCA-associated vasculitis and the influence of ANCA subtype. At the time of diagnosis, the 78% of the patient had abnormal thoracic CT study. The most common abnormality was nodular disease, followed by bronchiectasis and pleural effusion. And central airway disease and nodular pattern of pulmonary involvement are more common in PR3 ANCA positive patients, and visual interstitial pneumonitis and bronchiectasis are more prevalent in MP ANCA positive patients. This is the CT finding of different presentations of ANCA-associated vasculitis. And you can see there is pulmonary hemorrhage, and there is necrotizing pneumonia, there is usual interstitial pneumonitis, there is cavitary nodule, there is a small airway disease. CT involvement is common in GPA and MPA. The studies from National Institute of Health in United States shows the only 18% of patients presented with kidney involvement at the time of diagnosis. But subsequently, 77 to 85% of the patients develop the renal involvement within the first 2 years of the disease onset. The presentation varies from typical presentation is rapidly progressive glomerulonephritis, where patient presented with hematuria, proteinuria, and hypertension. This is the table which is showing the dermatological manifestation of ANCA-associated vasculitis. At the time of diagnosis, 30 to 50% of the patients presented with the dermatological manifestation. Among them, petechiae purpura is the most common manifestation. This is the picture showing the purpura. There is necrotizing ulcer in a patient of MPA, and there is digital gangrene in patient of GPA. Regarding the ophthalmological manifestations, the patient may present with conjunctivitis, peripheral ulcerative keratitis, episcleritis, scleritis, retinal vasculitis, uveitis, granulomatous orbital or retroorbital masses. This picture is showing the uveitis, and this is peripheral ulcerative keratitis. Uncarcinogenic vasculitis may present with some neurological manifestations like multiple motor neuropathy, sensory neuropathy, cranial nerve abnormalities, external ophthalmoplegia, and sensory neural hearing loss. 50% of the patients with GPA and 70% of the patients with MPA present with the peripheral nervous system involvement. In a study, data from the French Vascularity Study Group registry, they have shown that the GPA patients with baseline hypereosinophilia have higher disease activity at the time of diagnosis, with more skin and neurological involvement. The less commonly involved organ systems are GI tract, heart, lower genitourinary tract, thyroid gland, thyroid, liver, breast. This is an interesting article which I found during literature searching. There is some uncommon presentation of primary systemic necrotizing vasculitis, where GPA was presented as pneumofective subcutaneous phlegmon in the thigh. Another presentation was prostromegaly with obstructive uropathy and advanced renal failure, predominant GI vasculitis with thrombocytopenia and coagulopathy at the time of the presentation. GPA is the small vessel vasculitis involving commonly the skin, peripheral nervous system, kidneys, heart, and GI tract. There are three phases of the disease which comes one after another. The prodromal phase, which is characterized by atopic disease, allergic rhinitis, and asthma. The eosinophilic phase, which is characterized by peripheral blood eosinophilia and eosinophilic infiltration of the multiple organs, and followed by vasculitic phase, where life-threatening systemic vasculitis of the medium and small vessel are found, which often associated with vascular and extravascular granulomatosis. Asthma is the cardinal clinical feature of EGPA. More than 90% of the patients present with the asthma, which may precede the vasculitic phase by approximately 8 to 10 years. Upper airway and ear disease are also common in EGPA patients. Cardiac involvement is the most serious manifestation of EGPA, which accounts for approximately 1/2 of the deaths in patients of EGPA. Patient may present with the features of heart failure, pericarditis, cardiac rhythm abnormalities. Peripheral neuropathy is seen up to 75% patient of EGPA. And eosinophilic gastroenteritis, gastrointestinal bleeding, colitis are the manifestation of the gastrointestinal tract, and myalgia, migratory polyarthalgia are found in the musculoskeletal system involvement. Renal involvement varies in different studies in EGPA, but approximately 2 to 2% is found at the time of diagnosis. Patient typically present with presentation may vary from RPGN to isolated proteinuria or macroscopic hematuria. A positive test for ANCA was found in all patients presented with glomerulonephritis in EGPA. The association with the cardiovascular events. A cardiovascular event occurred in 14% of the patients during 5 years of follow-up of 4 European Vascularity Study Group trials of GPA and MPA. PR3 ANCA positive status was associated with reduced cardiovascular risk compared to MPO ANCA or ANCA negative status. Dysfunction of the immune and coagulation system contributes to an increased risk of venous thromboembolism, especially during active disease. Imaging play an important role in establishing the diagnosis of uncarcinogenic vasculitis, especially GPA and MPA, which we may use sinus computed tomography, chest radiograph, and HSCT. I've shown the HSCT findings in my previous slide. Regarding the tissue biopsy, whenever possible, the diagnosis of GPA or MPA should be confirmed by biopsy of a site of suspected active disease. If a biopsy cannot be performed immediately, then the therapy should not be delayed, but we should try to obtain the biopsy as soon as possible after initiation of the therapy. Tissue usually obtained from skin or kidney. This commonly lung biopsy can be performed thoracoscopically. The histopathology, the hallmark of the acute injury in all forms of uncarcinogenic vasculitis are fibrinoid necrosis, inflammation of the small vessels accompanied by thrombosis. In MPA, features are present without granulomas or prominent eosinophilic infiltrates. Chronic lesions are characterized by transmural scarring with loss of the elastic internal lamina. These are the histopathology slides where you can see in acute case there is a necrosis. In chronic case there is a narrowing of the lumen and there is fibrosis. and there is geographic necrosis. In EGPA, abundance of eosinophil is the defining feature. Here in this slide, you can see the eosinophilic infiltrates. In early stage, there will be no necrosis. In later stage, the eosinophil will surround the epithelial cell within the granuloma and necrosis will be present. This is the algorithm for the diagnosis of uncancerous vasculitis. When patient is suspected as Gpa, Mpa, or limited uncancerous vasculitis, we should evaluate by taking comprehensive history and doing the physical examinations. Some laboratory testings are done for testing of ANCA, serum creatinine, immunolysis, ESR, CRP, and some tests are done to exclude the other diagnoses like ANA, anti-Gpa antibodies, C3, C4 complement, cryoglobulin, screening of hepatitis B, C, and HIV, and for a safety to liver function test and tuberculosis skin. And in imaging, we can do the CT test. If it is ANCA, it is positive, tested positive, then we should go for the tissue biopsy. If this is consistent with the diagnosis, then the diagnosis is established. The differential diagnosis of Gpa and Mpa include polyarteritis nodosa, anti-GBM disease, drug-induced uncancerous vasculitis, infection, malignancy, concurrent glomerular diseases. And the differential diagnosis of EGPA includes, other than the Gpa and Mpa, includes the exacerbated respiratory disease, chronic eosinophilic pneumonia, hypereosinophilic syndrome, and other vasculitis. This table is showing the difference of the PR3 and the Mpa positive ANCA. You can see the age at diagnosis of the PR3 ANCA is 45 to 60 years. And the MPO ANCA, it is 60 to 70 years. Male are more commonly affected by PR3 ANCA, and PR3 ANCA is more prevalent in Northern Europe and Americas, and MPO ANCA is more prevalent in Asia and Southern Europe. The risk factors of PR3 ANCA include Staphylococcus aureus, and the risk factors for the MPO ANCA is the drug, hydrolyzing lymphoma and uracil. Clinical phenotype, PR3 ANCA is more associated with Gpa, and MPO ANCA is more associated with Mpa. And granulomatous in manifestation of ear, nose, sinus, upper airway involvement, and pulmonary nodule are more common in PR3 ANCA. Pulmonary fibrosis, bronchiectasis, and increased severity of chronicity of renal disease are commonly found in MPO ANCA. And PR3 ANCA is more, rituximab may be superior to cyclophosphamide for remission induction in PR3 ANCA, and rituximab likely equivalent to cyclophosphamide for remission induction in MPO ANCA. And relapse is more common in PR3 ANCA, and non-fatal CVD events are more commonly found in MPO ANCA. In EGPA, the presence or absence of ANCA in patients defines its two subtypes. In ANCA positive EGPA, ANCA is almost always specific to MPO, and renal involvement and peripheral nerve involvement are more common in ANCA positive EGPA patients. And cardiomyopathy and pulmonary infiltrates are more common in ANCA negative EGPA patients. After establishing the diagnosis, disease assessment should include disease measurement of the disease activity and damage. Disease activity, we can measure the disease activity by using the Birmingham Vasculitis Activity Score and 5-factor score. The damage can be measured by Vasculitis Damage Index. And quality of life, in previous clinical trials and clinical practices, SF36, EQ, 5D, and health assessment questionnaire was used for assessing the quality of life. Recently, OMERACT Vasculitis Working Group developed a 29-item patient-reported outcome, the AAV-PRO questionnaire, which covers 6 domains: organ-specific symptoms, systemic symptoms, treatment adverse effects, social and emotional effects, concern about the future, and physical functions, for assessing the quality of life in uncancerous vasculitis. The management of uncancerous vasculitis is a big chapter. I'm just, I'll tell about only the outline of the management of uncancerous vasculitis here. The therapy can be divided into the induction of remission and the maintenance of remission. Treatment should be initiated as soon as possible. The diagnosis of uncancerous vasculitis is made, and we should keep it in mind that we should not wait for obtaining a biopsy, as several days of treatment usually does not markedly reduce the diagnostic yield of a biopsy. The glucocorticoid is still the mainstay of treatment. in organ and life-threatening cases condition, we can use IV pulse methylprednisolone followed by oral prednisolone, and along with the immunosuppressive agents like cyclophosphamide or rituximab. And as a therapy in methotrexate, MMF can be used as maintenance therapy. In non-organ threatening disease, we can use MTX, MMF, or rituximab for remission of induction. And induction should be continued for 3 to 6 months, and maintenance should be continued for at least 18 months, ranging from 24 to 48 months, and long-term follow-up should be done in all patients. This is the table showing the key clinical trials noted for the remission of induction, which includes the Cyclops trial, the RAVE, the Retuvas, Meplex, and I want to draw your attention about the Advocate trial, where avacopan has been used, and it shows the promising results in for its glucocorticoid sparing role. Adjunctive therapy includes vaccination, prophylaxis for rheumatic neuropathy, bone protection, management of hypertension and hyperlipidemia, and anticoagulation for venous thromboembolism. Once upon a time, ANCA vasculitis was a remarkable disease with remarkable mortality and morbidity. But with the invention of the recent immunosuppressive agents, the mortality has declined, and the 5-year survival of ANCA vasculitis steadily rising to around 70 to 80% over the past 40 to 50 years. The clinical factors influencing outcomes are older age, severity of renal dysfunction, pulmonary hemorrhage, disease activity measured by Birmingham vasculitis activities score, infectious burden, development of first relapse within 1 year, and amount of chronic damage measured by vasculitis damage index. There is increased likelihood relapse in GPA, PR3 ANCA, and when there is upper and lower respiratory tract involvement, which is approximately 50% by 5 years after diagnosis. We, the rheumatologist, our aim of treating a patient is not only to help the patient to live, but also to live a qualityful life. Now, the evolution of the immunotherapeutics has transformed ANCA vasculitis into a chronic disease. So the patient's priorities have realigned. Patients rank quality of life domains such as fatigue and pain as the greatest disease priorities. So there are key differences between patients and clinicians' perception of the priorities. So when the clinician is more concerned about the infection due to the use of immunosuppressive agents, but the patient is more concerned about their moon face, cushion-joint appearance, about their fatigue and their joint pain. A national cohort indicated that the patients with ANCA vasculitis experience substantially poorer level of physical and mental quality of life than match control in the general population, even though the vast majority of patients had achieved disease remission. This is a recent study which is showing the impact of ANCA vasculitis on employment and work disability in an Australian population, where you can see the rate of work disability was 23.4%, and 44.7% of the respondents reported their financial stability had been negatively impacted by their vasculitis diagnosis. In conclusion, early detection and appropriate intervention can help reducing mortality and morbidity. Close monitoring is necessary throughout the disease course, especially infection is a big concern for these South Asian countries. A multidisciplinary approach and patient engagement would result in a more integrated treatment strategy and improved outcome. ANCA vasculitis are challenging and complex condition, but an integrated collaborative approach, including the considerable patient involvement, progress can be made by improving the lives of the patients with these diseases. With this, I want to conclude my session. Before ending, I would like to express my gratefulness to Professor Minhaj Rahim Choudhury for his inspiration and kind support. Thank you everyone for your patience hearing.
Thank you very much, Dr. Tania Kobir. Dear audience, you have any question, please drop it in the chat box. And after another session, we will discuss on, we'll talk in the question and answer sessions. Thank you very much for a nice presentation, Dr. Tania again. I would like to request for the next presentation, Dr. Farjana Shumi. She will present the another part is the cutaneous vasculitis. So I'd like to request Dr. Farjana Shumi, and she is the consultant at Square Hospital, Dhaka.
Am I audible?
Yes, audible. Audible.
Thank you, Dr. Shahin, and thank you, BRS, for giving me the opportunity to present in this platform. And my respected teachers and mentors are here, and distinguished panelists from home and abroad, and all my juniors. Assalamu alaikum. Today, I'm going to present cutaneous vasculitis. First of all, I would like to say some words regarding cutaneous vasculitis, like it encompasses wide and heterogeneous group of disorders characterized by the presence of necrotizing inflammatory lesions in the cutaneous blood vessels. So what does it cause? It can be the cutaneous component of systemic vasculitis, like cutaneous manifestations of IgA vasculitis. It can be skin-limited or skin-dominant expression or variant of a systemic vasculitis, like skin-limited IgA vasculitis. But it can be only single organ vasculitis of the skin. These are the dermal vessels. Usually the skin comprises subcutaneous tissue and mucosa, and vasculitis usually involve the superficial vessels, but as well as it can involve subcutaneous, but rarely it involves the mucosa. You can see here the dermal vessels comprises vein, venule, capillary, arterial, and sometimes small arteries. And Chapel Hill Consensus Conference defined small vessel vasculitis on structure and function rather than diameter, and define medium vessel vasculitis when it involves mainly visceral arteries. And this is a Chapel Hill Consensus Conference named Vasculitis in 2012. These are the vasculitis: large vessel, medium vessel, small vessel, variable vessels, single organ vasculitis, vasculitis associated with systemic disease, and it can be associated with probabilitology. And it has been nicely described by my previous presenter, Dr. Tania Kubir. And I love skin. This is not my speech. This is the most common promotional signboard of beauty center of dermatology clinic. And interesting thing is that most of the vasculitis, as you have seen in the previous slide, named by Chapel Hill Consensus Conference, love skin. Why it love skin? Because skin has large vascular bed. It has important hemodynamic factors like stasis in the lower extremities. Most of the immune complex deposit in the lower extremities because of its gravitational effect, and of course of environmental influences like cold exposure. So next few slides, I will describe the vasculitis, how the vasculitis involves skin, and as well as I will share some of my experience of cases. This case is taken from internet. This is not my case because this type of case usually you do not encounter. This 72-year-old man developed painful necrotic ulceration of the scalp and as well as acute headache, and CRP was high, and ambulatory biopsy showed a granulomatous vasculitis of vessel wall with collections of macrophages, neutrophil, and Janssen. So you already have known that this is Janssen arteritis. And according to Chapel Hill Consensus Conference, among large vessel vasculitis, in Takashu arteritis, there is no definite vasculitic lesion in the skin. But in some literature, it has been described that erythema nodosum can be present in Takashu arteritis. And in Janssen arteritis, already have seen there is necrosis in the skull. So there is occlusive and very rarely involvement of small arteries in subcutaneous ulcer. So what is the cutaneous disease has been described in Janssen arteritis? It can involve, it can cause ischemic necrocutaneous manifestation, abundant,
ঘরে প্রেমময় স্ত্রী থাকার পরও কেন পাষণ্ড প্রেমিক বর্ষণ মিথ্যে ভালোবাসার ফাঁদে ফেলেছিল 17 বছর বয়সী কন্যাকে
and it causes nodules and paniculatis like lesions like cutaneous nodules, cutaneous lesions resembling erythema nodosum. So this is my case. I have encountered this case around 1 year back. She was 18-year-old lady, developed skin rash in both upper and lower limbs, and you have seen that libido reticularis, like skin rash in her upper limbs and lower limbs, as well as she has had numbness in both upper and lower limbs. But apart from numbness, there was no other assessment features like fever, weight loss, and which other involvement. An interesting thing is that her brother also suffered from polyarthritis. He has had acute pain, and his symptoms started since he was 4 years of age. And we did nerve conduction studies of this lady and found she has a mixed sensory. She has had mixed sensory motor polyneuropathy. We did ANA and APS panel was negative as she has had libido reticularis. We could not perform genetic tests. She was treated as a case of cutaneous pan, and initially she received a steroid and azathioprine for the last 1.5 years. Now she's symptom-free. She's symptom-free from for neuropathy, and also skin symptoms have been resolved. So we don't know whether the patient is DAR2 deficiency or not. DAR2 deficiency has been described in 2014, like in Immunology. First, it was described in children, and symptoms vary from cutaneous manifestation to severe systemic polyarteritis nodosa. But I think Professor Aman sir is the first one who described DAR2 deficiency in adult patients, and he published a case series of DAR2 deficiency in Indian population. So we could not perform the genetic test, but we don't know whether this is the case of DAR2 deficiency or not. So in polyarteritis nodosa, apart from systemic manifestations, it can involve only the skin, which is known as cutaneous pan, and Kawasaki disease, it doesn't involve skin. As among unclassified vasculitis, the presentation actually described my previous presenter and Daniel already mentioned that drug-induced unclassified vasculitis can be limited to the skin, especially after taking total thyroid. And in Mpa, it can also be stimulated, and Gpa, it can also be stimulated. In PGIMER, it can also be stimulated. So this case, he was 65-year-old man. There was cutaneous ulcer. You can see here, and as well as he has had polyneuropathy and opacity from the age of the ulcer with before cytoplastic vasculitis. And serum protein erythropoiesis was done, and it showed long-term and bone marrow showed more than 30% blood vessels. We could not do serum creatinine level because it is not available in our hospital, in hospital in Bangladesh. So we don't know whether it is case of creatinine vasculitis associated with multiple myeloma, but this is a case of multiple myeloma with vasculitis itself. So cardiac vasculitis could be
একটা ডোনেশনের ব্যাপারে বলো ম্যালকম
and cardiac vasculitis of the skin can be either systemic vasculitis. And IgA vasculitis can also be skin-limited, only skin-limited IgA vasculitis.
আমাকে তো বললো তুমি জানো
So this case is very interesting. She was 37-year-old. She has had rash for last 3 days with severe itching, burning sensation. When she got admitted, she has had shortness of breath, and in the emergency department, she received IV hydrocortisone, and she had severe urticaria involving upper limbs. The picture is not very clear because I have taken the picture after she received injection hydrocortisone, because she already received it in emergency department. And according to her statement, the symptoms started after she taking sulfasalazine. And with this severe urticaria, she had severe arthritis involving mainly upper limbs. And apart from her previous history revealed that apart from dry eye, no past present history of conduction disease. She's received sulfasalazine after having a long suffering, like 1 year of arthralgia and body ache. And we did some lab tests and found NA was positive, and the SSA was positive, complements were normal, and Sharma test was done and it was also positive. Ultrasound of parotid gland consistent with Sjogren's syndrome. So we made the diagnosis, arterial vasculitis probably associated with Sjogren's syndrome. She was treated with prednisolone as well as hydroxychloroquine, and now she is symptom-free. So articular vasculitis could be hypocomplementic, that means the complement levels are lower in the blood, and it could be normocomplementic. In hypocomplementic articular vasculitis, there are more systemic features like involvement of the kidney, lungs, as well as other organs like eye. But in normocomplementic vasculitis, there are less systemic features. So vasculitis could be associated with the systemic disease, like it could be associated with the connective tissue disease, lupus, RA, sarcoidosis, can be associated with global etiology like drugs, infections, sepsis, and autoimmune disease. And now I'm moving to another case. This case I have published in Tropical Doctor in 2018 when I was fellow in the Department of Internal Medicine, the cutaneous leukocytoclastic vasculitis in visceral leishmaniasis. This lady was from Shoipur, which is endemic for Kalazar. She presented with low-grade fever and purpura in her lower limbs. We did skin biopsy and found leukocytoclastic vasculitis, but there was no immune complex in diffuse immunofluorescence test, and Kalazar was proved by ICT for Kalazar, and LD body was found on splenic aspirates. And she was treated with liposomal amphotericin B and completely cured from this sort of purpura. So vasculitis in infection, I want to mention that these references I have taken from a review article written by our respected teachers, respected professor, Syed Atiqul, and it was published in International Journal of Rheumatology in 2019. Vasculitis in infection has been described by several mechanisms like cell-mediated hypersensitivity, abnormal immune regulation, production of cytokines such as TNF and various interleukins from direct stimulation of infectious agent, type 3 immune complex reaction, and it can be with direct endothelial invasion. But in human visceral leishmaniasis, it has been described in vitro, of course in vitro, that it has been described. It could be associated with mixed cryoglobulinemia and generalized autoimmune activation. So we have described vasculitis in visceral leishmaniasis in this way because it could be, this was hypothesis, it could be decreased nitric oxide production. In vitro, it has been described in visceral leishmaniasis, it affects microvascular function. Purpura could be due to mechanical impairment of the blood vessel by the parasite. But as in our patient, I have told that there was no immune complex in vessel wall and no organism was isolated.
Recording in progress.
So we have described that the vasculitis could be the above mentioned mechanism except the type 3 immune complex and direct endothelial invasion, like you have seen in the previous slide. It was not due to type 3 immune complex because there was no immune complex deposition in immune fluorescence, DIF. There was no organism found, so it was not due to direct endothelial cell invasion. It could be due to cell-mediated hypersensitivity, could be due to abnormal immune regulation. So this case I've encountered 7 months back. He was 27-year-old man. He developed painful erythematous nodule in his lower limbs associated with ankle arthritis. At first presentation, the nodule was not ulcerated, but later it became ulcerated. You can see here. So we did some routine tests like CBC was normal, ESR was raised, autoantibody profiles like first of all, it looked like erythema. So we did some autoantibody profiles, ANA, ANCAS, rheumatoid factor, all were negative, HST was normal, so biopsy was done and it showed acute and chronic inflammatory cells, including many epithelial cells and giant cells. And surrounding area displays fair number of granulomas composed of epithelial cells and giant cells, and no lesion was seen. And he was treated with antitubercular chemotherapy for 6 months, and after having antitubercular chemotherapy, this is his recent picture. It showed only post-infectious hyperpigmentation, and there was no arthritis or pain. So I have already described the various forms of vasculitis, large, small, and infection, all things. But in cutaneous single organ vasculitis, it has been mentioned that it could be cutaneous IgG immune complex vasculitis. It could be nodular cutaneous vasculitis, which has been described as erythema induratum of Bazin, and it has been described in, I think, 1844 by Bazin, and it could be erythema elevatum diutinum. So what is cutaneous single organ vasculitis? In 2012, revised Chairperson Consensus Conference, it has been defined as it confined to the skin, and the Entity is equivalent to the previous cutaneous lymphocytoclastic anxiety described in 1994, and it is a histological term. In the next slide, I want to show that it is different from the hypersensitive vasculitis because in some literature, some author, these terms are interchangeable like cutaneous lymphocytoclastic vasculitis, single organ cutaneous vasculitis, hypersensitive vasculitis. But I would like to say that it is quite different from the hypersensitive vasculitis because in hypersensitive vasculitis, there are systemic features, more systemic features, fever, arthalgia, and in hypersensitive vasculitis, usually occur after exposure of drugs or infections, and biopsy is not essential to diagnose hypersensitive vasculitis, but it is essential to diagnose isolated cutaneous lymphocytoclastic angiitis. Here you can see that there is a diagnostic criteria of hypersensitive vasculitis given by classification criteria, and it was given by American College of Rheumatology. So I would like to describe pathogens in short because the pathogenesis, unconstituted pathogens have been nicely described by Dr. Tania Kobe. And cutaneous vasculitis, in some literature, it has been described as it could be unconstituted, it could be non-unconstituted. I'm showing you here is non-unconstituted pathogenesis. Like all of you know that the membrane is consists of cardiolipin and cardiolipin and phosphatidylserine. When it is exposed on the outside of the cell membrane during apoptosis or by damaged endothelial cell, prothrombin binds officially to the surface of the endothelial cell and it combined with phosphatidylserine. After that, this complex causes anti-phosphatidylserine prothrombin antibody. Eventually, it activates endothelial cell, produce hypercoagulable state and leading to thrombosis. As well as it also releases some inflammatory mediators like interleukin-8 and neutrophil promote coagulation and providing procoagulant surface, all which to amplify the signal and inhibit natural anticoagulant mechanism. And subsequent complement activation might be due to hemoglobin aggregates. And some literature, it has been described that it could be due to dry infection. Especially, it is described in rickettsial infection. It could be due to diarrhea infection. It could be due to type 1 allergic or anaphylactic reactions, as in EGPA. It could be due to type 2 antibody-mediated cytotoxic reaction, like Gpa, Mpa. It could be due to type 3 immune complex reaction, like cryoglobulin vasculitis and IgA vasculitis. It could be type 4 cell-mediated hypersensitivity reaction, as in giant cell arteritis or Dhaka arteritis. So this is a diagnostic algorithm. I think we could follow this to diagnose when patients present with the cutaneous vasculitis. It is not only primary, it is an approach of cutaneous vasculitis, and by excluding all this, we can diagnose primary cutaneous vasculitis. First step, we have to suspect. Second step, we have to be careful about mimickers. Third, we have to exclude collagen disease, cancer, infection, and drug, erythema elevatum duodenum, and facial granuloma, because it has characteristics, very, very distinct characteristics, skin characteristics, and it can be easily excluded by spa dermatologists. Like facial granuloma involve the face, and erythema elevatum duodenum, it has very special characteristics, involve upper and lower limbs. Fourth step, we have to do biopsy. And the fifth step, we have to be very careful about the interpretation of biopsy because we have to exclude incidence of vasculitis. And finally, we have to appropriate manage the patients according to etiology. So first step, when we will suspect vasculitis, if patients are present with palpable purpura, ulcerated nodule, livido reticularis like lesion, some subcutaneous nodule, and livido racemosa like lesion, and vesicle like lesions in the lower limbs, and urticaria. Second step, we have to look for mimickers like chilblain lupus. We can exclude it by taking history. It is Shamrock disease and vitiform purpura due to cholesterol emboli. It could be excluded by taking history. Vitiform purpura due to APS. It is also very important to exclude by taking history. This is bed bug, very common, and this is solar purpura, which is very common in elderly populations, and purpura due to non-palpable purpura due to thrombocytopenia, and livedoid vasculopathy. This is also very common mimickers. For instance, we have to do some autoantibody profiles if patients have connective tissue disease, history or symptoms of connective tissue disease, or for the exclusions like ANA, RA, UNCAS, and screening for infections like hepatitis B and C, and I'd like to mention that there are several infections reported in vasculitis, like varicella. There are some case reports that varicella zoster virus present in temporal artery in giant cell arteritic patients. So not only these viruses I have written here, there are several viruses and bacteria we should screen if patients have appropriate or relevant history. And we have to do malignancy screening if patients had appropriate history. The fourth step is biopsy, but we should be careful that when to do. So we can delay a biopsy if patients have persisted skin lesion for less than 4 weeks. If we get clear, removable or treatable inciting factor like drugs and infection, if patient has had no clinical or laboratory evidence of systemic involvement, but we must perform the biopsy. If vasculitis fails to improve within 4 weeks, like new lesions developing or persistence of red or purple lesion. So this is a biopsy technique is showing punch biopsy. It involves the dermal vessels, superficial vessels, but if we want to take the deep vessels, muscular vessels, we have to do the deep punch biopsy or wedge biopsy, or we can do incisional biopsy. You can see here that cutaneous leukocytoclastic angiitis and Hinchman and purpura involve the superficial dermal vessels. ANCA-associated vasculitis, cryoglobulinemia, and connective tissue disease-associated vasculitis involve superficial as well as vessels in the muscular layer. And polyarteritis nodosa, giant cell arteritis, and nodular vasculitis involve vessel in the subcutaneous tissue, and it needs deep punch biopsy or incisional biopsy or wedge biopsy to take vessels from the subcutaneous tissue. So what is the timing of the biopsy? This is very important because in cutaneous vasculitis, we have to take that if the lesion is between the 24 to 48 hours old, and this is the most appropriate time for routine biopsy. Why not before 24 hours? Because if we take biopsy before 24 hours, we will not get fibrinoid necrosis, which is very important histopathological features of biopsy. Histopathological features I will show you later. And if we take after 48 hours, neutrophils usually replaced by lymphocytes, so we'll not get the typical features of neutrophilic vasculitis or leukocytoclastic vasculitis. And we have to do DIF within 8 and 24 hours of age of the lesion, because the time has been passed, like after 24 hours, after 72 hours, there will be no immunoglobulins, only complements will be there. And after 72 hours, we'll get only complements if we'll do DIF. So you have to send 2 biopsy specimens. One is in normal saline for DIF and one is formalin for histopathological examination. So what is the location of the biopsy? If we want to do biopsy, we have to do in particular lesion can be taken from any site within the lesion. But in case of livedo racemosa, we have to take it from the pale center of an erythematous ring, because this is where the responsible vessel is likely to be located. And regarding livedo reticulosa, there is some debate. Some of the articles had shown that there is no need to take biopsy from the livedo reticularis, but in some articles it has been written that we can take biopsy from the center as well as in livedo racemosa to diagnose livedo reticularis, to exclude other causes of livedo reticularis. And from ulceration, we can take biopsy from the edge of the ulcer rather than ulcer itself, because if we take the biopsy from the base of the ulcer, it will reveal purely incidental findings. So we have to take biopsy from the edge of the ulcer. And if there is nodule, we have to take biopsy from the center of the nodule. And be careful, please do not take biopsy from the infarcted disease, because it's generally low yield for evaluation for vasculitis, as the infarct is simply a manifestation of underlying vessel obstructions, and will not get any information if you take biopsy from the infarcted disease area, apart from some cell infiltration because of incidental vasculitis, incidental finding. So here I'm showing all of you that the important histopathological criteria of small vessel vasculitis as well as medium vessel vasculitis. The important histopathological criteria is 2 out of 3 of the following should be present, like angiocentric and angioinvasive inflammatory infiltration. Regarding angiocentric and angioinvasive, I would like to ask all of you which is more important, angiocentric or angioinvasive. But the more important is angioinvasive inflammatory infiltrates. And disruption and the destruction of vessel wall by the inflammatory infiltrate, because you should be careful that the disruption and destruction of vessel wall could be due to invasion from the organism like bacteria, like parasite, like fungi, or by invasion of the tumor cells. So be careful that disruption and the destruction of the vessel wall should be by inflammatory infiltrate. And these two are very important findings, but in some authors describe that fibrinoid necrosis is the most important histopathological findings of small vessel vasculitis, like fibrin deposition within the vessel wall lumen, and results from the accumulation and conversion of plasma protein because there are vessel wall disruption. So there are more plasma protein accumulation, more coagulation factor. So there is fibrin deposition in the vessel wall. So all of the three criteria, along with clinical features, we should be careful to diagnose vasculitis. So in median vessel vasculitis, the inflammatory infiltrate, the muscular vessel wall as well as fibrinoid necrosis is present. This is a very popular question and asked in the exam. The histopathological features of leukocytoclastic vasculitis, neutrophils invading the vessel wall, fibrinoid necrosis or fibrin, nuclear dust, extravasate erythrocyte, perivascular inflammatory cell infiltration, mainly neutrophil, and endothelial swelling. So what are the additional histopathological findings which will guide all of us to diagnose vasculitis, like the presence of granuloma can help us to diagnose Gpa and Mpa, interface dermatitis, like immunoglobulin deposition and complement deposition between the dermis and the subcutaneous tissue, dermal and subepidermal junction, in lupus and dermatomyositis. But in vascular dermatosis, there is sub-intraepidermal pustule, like present in septic vasculitis and infection. So in DIF, we will get some important information like if the DIF is negative, so it will cause immune vasculitis like Gpa, Gpa, ANCA-associated vasculitis. But if IgM is present around the vessel wall, it could be due to type 2 or 3 cryoglobulinemia or dermatovasculitis, IgA deposition, HSP or IgA vasculitis, IgG, complement, and fibrin on vessel wall as well as along the dermal epidermal junction could be due to hypercomplementary articular vasculitis. So be careful about the incidental vasculitis. Already I have mentioned that trauma or ulceration damage that is restricted area, we can differentiate by this finding, because if the features of vasculitis, infiltration of cell due to trauma or ulceration should be restricted in this area, should not be present in the normal area. So precaution biopsy species should also be obtained from non-ulcerative site. By these, we can differentiate from the incident of vasculitis. In case of neutrophilic dermatosis, it affects the vessels within the diffuse dermal neutrophilic infiltrate compared with the angiocentric neutrophilic infiltrate of leukocytoclastic vasculitis. What are the pitfall? Pitfall is pseudovasculitis, bacteria and fungi and tumor cells rather than inflammatory cells, and another is fibrinoid necrosis. It will also be caused by dermal and subcutaneous abscess or necrosis apart from vasculitis. So another pitfall is sometimes we overlook the main vasculitis lesion because sometimes vasculitis is present as a segmental lesion. And features of vasculitis may be missed on the initial hemotoxin and eosinophil scan section. So we should take serial sections if we have strong suspicion for vasculitis. So here you can see the serial section is showing the features of vasculitis. So before going to the management section, we should always remember the speech of the Voltaire. He's famous French philosopher and writer. He told that the art of medicine consists of amusing the patients while nature cures the disease actually. So remember that cutaneous vasculitis, I'm talking about the management of the isolated cutaneous vasculitis, non-vasculitis, cutaneous vasculitis due to other causes. The isolated cutaneous vasculitis could be self-limited. It could spontaneously resolve within 2 to 4 weeks. So management should be for acute and uncomplicated acute idiopathic cutaneous small vasculitis like breast, leg elevation, and compression stocking will help to prevent the deposition of immune complex in the legs, NSAID for pain management, and oral antihistamine receptor pruritus. But if it is complicated, like when we say it is complicated, if the cutaneous lesion can produce necrosis ulceration, if active disease persists for more than 4 weeks, and if history of prior recurrence, we should manage the patient by steroid, and we can gradually taper over 3 to 6 weeks. But if the lesion relapse or inadequate response, we can add colchicine. We can increment the dose of colchicine as well as we can start dapsone. And we can also combine the colchicine and dapsone. And we can continue colchicine until resolution of active lesion or new lesion develop for 2 to 3 months. We can taper to discontinuation over 4 weeks. And if patient has had no response or like we can use immunosuppressive medication as azathioprine, VMMF, and methotrexate. And also other agents can be used like minocycline, rituximab, and IVIG. But remember, the topical corticosteroids have not been formally evaluated in the treatment of cutaneous small vessel vasculitis. So how long should you continue the treatment? The duration of treatment is still unknown because if response has been achieved, the decision to taper and ultimate discontinuation must be made on case by case. Like if the patient has continuously cutaneous erection, we should longer the therapy. If patient has cluster resolution, we can shorter the therapy. In general, it is reasonable to consider tapering after remission for 3 to 6 months. So this is the last case. This is a case report published in 2021. Cutaneous vasculitis. This gentleman developed following COVID and vaccinations, and they evaluated all the other causes of cutaneous vasculitis. No family, no personal history of vasculitis. All antibodies, autoantibody profiles were negative, and they did biopsy and found glycocytic acid vasculitis, and they treat the patients by giving steroid. So this is the last case scenario. I would like to conclude by warm wishes for my winter garden, and wish you all have a good health and longer life. Thank you all.
Thank you very much, Dr. Farjana Shumi, for your nice, elaborating, and informative presentation. And we are very lucky. We have actually vasculitis specialist, especially Professor Syed Atiqul sir, Professor Aman Sharma sir, and Professor Minhaj Choudhury sir. So Minhaj Choudhury sir is mostly interested in the large vessel vasculitis like BC and Dhaka arteritis. But we are very lucky. We have a real experts on the vasculitis. So now I am going to the question and answer session. We have two questions. First question is from the Atiqul Rahman to the Dr. Farjana Shumi. How can we clinically differentiate livedoid vasculopathy and cutaneous vasculitis? Dr. Farjana Shumi.
Thank you for this nice question. Clinically, livedoid vasculopathy has some very special features like atrophy blanchi and atrophic scar. But in cutaneous vasculitis, this atrophy blanch, atrophic scar usually not present. And this is the way we can say clinically. But of course, sometimes it is very difficult. But these are the specific features of livedoid vasculopathy.
I would like to request Professor Aman Sharma if you would like to add something regarding this question. How can we clinically differentiate livedoid vasculopathy and
that's an excellent question. As beautifully presented by Dr. very recently, cutaneous vasculitis is a big spectrum, and it starts off. It basically depends upon as she had said, the size of the vessel involved. If it is a very small superficial vessel involved, then it will present something like palpable purpura, and which is a sine qua non of small vessel dermal skin vasculitis. Whereas when the deeper vessels are involved, then they will have a different spectrum, like you can have even cutaneous infarction and all those kind of manifestations, which are more representative of medium vessel vasculitis like polyarteritis nodosa or DADA2. The dilemma comes when there is a livedoid kind of presentation, as Professor Haq has very beautifully asked the most important question. It is at times it is very difficult. If you have other features of medium vessel vasculitis along with it, then your life is easy. Otherwise, it is basically the conundrum or the combination of clinical presentation. If it is only confined to the skin, it might be practically impossible to differentiate livedoid vasculopathy from vasculitis, livedoid vasculitis. And in fact, even in, to confuse the matters further, even in a medium vessel vasculitis like DADA2, on a skin biopsy, you can have a spectrum of either livedoid vasculopathy on histopathology or histopathology showing vasculitis. So the older literature, if you dig out from the the dermatology literature, the livedoid vasculitis, vasculopathy was thought to be because of the thrombotic states, and people used to give anticoagulants also, and even rheological agents, and eventually ended up using our own spectrum of steroid cyclophosphamide, and ended up being using even anti-TNFs, which are used in treatment of DADA too. So I believe that a part of that cluster of livedoid vasculopathy would have been at least in part contributed by the medium vessel vasculitis. But those things are being teased out as we know more and more about these autoinflammatory syndrome. Having said that, it is clinical presentation, inflammatory markers, and histopathology, which in totality will differentiate whether it is a vasculitis or vasculopathy. But I can tell you at times it might be very, very difficult. But generally, if you see these things together, then it might help. I hope I have not confused further, rather I have tried to clarify.
Okay, thank you, sir. I'd like to request a panel of experts if you have any comments regarding these questions.
Just I'd like to say just one point. It's okay. Definitely what Professor Aman Sharma told is clinically sometimes very difficult. And again, what we should give emphasis on history taking and clinical examinations, and then in the end we need to go for a biopsy. So the scenarios sometimes may mimic. We have to keep it in mind, though the things are different. Thank you.
Okay, thank you, sir. Professor Minhaj Choudhury, sir. We have the next question from the Vidhan. There are two different timings for biopsy and DIF. How can we manage these at one settings? This question is to the Dr. Farjana Shumi.
Thank you, Dr. Vidhan, for this nice question. And we can, I think that we can say before 24 hours. And as I mentioned that after 72 hours, hemoglobin disappear. And before 24 hours, fibrinoid necrosis, which is very important histopathological features of vasculitis, will not appear, will not get these features. So just 24 hours or 24 to 48 hours is the best time to obtain biopsy, because at the verge of the 24 hours or just after 24 hours, you will get neutrophils, you will get fibrinoid necrosis, and you will also get the immunoglobulins in DIF. So this is the best timing to take biopsy, of course. And after 48 hours, you will not get the neutrophil. And before 24 hours, you will not get the fibrinoid necrosis. And after 24 hours, actually, the hemoglobin started to fade out or decline in the skin. So in 24 to 72 hours, you will get also the hemoglobin. So I think that at the start of the 24 hours, just after 24 hours, this is the best time to take biopsy. Thank you.
Thank you, Dr. Farjana Shumi. I would like to
Dear moderator, may I add just one point here that
yes,
has
sir.
to be that has to be remembered by all the residents and the junior doctors, that when we will ask for a biopsy, we should not forget one point, that we have to ask the surgeon that the samples should be preserved in two separate containers. As you understand, the normal saline is necessary for DIF. So that has to be remembered. Thank you.
I'd like to request to the panel of experts if you have any comments regarding this question. There are two different timings for biopsy and DIF. How can we manage this in one settings?
Thank you. Actually, it is very difficult to do different setting two times, particularly in our country, I think for India also, because only 1 or 2 days apart, 2 times biopsy, to perform biopsy, it is difficult. So better try to overlap. Dr. Farjana Shumi nicely answered the question after 24 hours. And another question is two container. Yes, when we do biopsy, same time we have to send to for two tests for two container, one for normal saline and one with formalin. And I think it is wise for us. It is not possible for two setting. Thank you.
Okay, thank you, sir. This is probably the last question. How does the small vessel vasculitis manifest the features of medium vessel vasculitis? This question he did not mention.
Tanya COVID, please.
This is actually goes for the Tanya COVID. Tanya COVID. How does the small vessel vasculitis manifest the features of medium vessel vasculitis?
Thank you for the nice question. The vasculitis, the primary vasculitis has been differentiated into large, medium, and small vessel vasculitis depending on the predominant vessels involved. That is, small vessel vasculitis, the predominant vessels, predominantly involved vessels are small vessels, but it's not that it cannot involve the medium vessel also. In the necrotizing vasculitis like angiostotic vasculitis, though it is predominantly involve the small vessel, this may also involve the medium vessel and can show some manifestations of small vessel vasculitis.
Thank you, Dr. Tanya COVID. I would like to request from the panel of experts if you have any comments regarding this.
Actually, patient who in small vessel is involved, patient will present like small vessel vasculitis. When medium vessel is involved, presentation should be like medium vessel vasculitis, like PAN. Actually, Dr. Tanya COVID answered predominantly which vessel is involved. Small vessel vasculitis cannot present with like medium vessel vasculitis. Predominantly small vessel vasculitis involved as well as medium vessel vasculitis. Medium vessel is involved. In that case, small vessel vasculitis patient can present with a part like medium vessel vasculitis. You can say rheumatoid arthritis. In case of rheumatoid arthritis, patient can present with all sorts of vasculitis: medium vessel, small vessel, large vessel vasculitis. Sometimes medium vessel vasculitis may involve small vessel. In that case, there is an overlap. When there is an overlap, small vessel and medium vessel, in that case, patient can present with both type of presentation, like small vessel and medium vessel. I think Tanya COVID mentioned like this. Thank you.
Thank you very much. Thanks. You have.
May I add something here?
Yes, sir. Yes.
Actually, if you look at the spectrum of when we talk about small vessel vasculitis and medium vessel vasculitis, there is quite a considerable overlap in the presentations, as has been highlighted by my previous worthy speakers. By and large, most of the manifestations, which as I said, I think it is just depicted by the addendum to the Chapel Hill nomenclature system with respect to the cutaneous counterpart, the CHCC addendum for the skin involvement, which highlights it beautifully. In small vessel vasculitis, especially prototype ANCA vasculitis, there can be a medium vessel involvement also, although the dominant involvement is small vessel. But it can rarely have manifestations exactly like medium vessel vasculitis. When I say exactly like, the prototype microaneurysms, which are seen in polyarteritis nodosa, can occasionally be seen in ANCA vasculitis also. We've seen it, it's there in the literature, it is rare, but whenever a small vessel vasculitis occasionally involves the medium vessels like the visceral vessels also, it can sometimes have a medium vessel vasculitis like presentation also. Whereas the thing which is not seen in classical polyarteritis nodosa is generally a lung hemorrhage kind of presentation, or the parenchymal lung involvement practically is never seen in classical polyarteritis nodosa, whereas it is different types of lung involvement, including the lung hemorrhage, are seen in ANCA vasculitis or other small vessel vasculitis. Having said that, rarely, even there are anecdotal case reports when there is a bronchial circulation involvement. There are case reports of lung hemorrhage also, although it would be rarest of the rare single case reports kind of a thing. So what I'm trying to say is there are certain pattern recognitions which we do for medium vessel vasculitis, like if there is a mononeuritis multiplex kind of presentation, if there is a dilated cardiomyopathy kind of presentation, or if there are larger cutaneous infarcts, or if there is hypertension, renal infarcts, microaneurysms, GI involvement, gut infarction, they go more like a medium vessel. Whereas some of these, although if ANCA vasculitis, you would have a sinus involvement, oral ulcerations, you would have nodules or lung hemorrhage, and you have, but with these, some of these manifestations of medium vessel vasculitis can also be seen in small vessel vasculitis. That's all that I wish to say.
Okay, thank you very much, Dr. Aman sir. Now, end of the question answer session. Now I'd like to request to from the panel of experts, first Professor Dr. Aman Sharma sir, Professor of Clinical Immunology and Rheumatology, Internal Medicine, Postgraduate Institute of Medical Education and Research, India. I would like request to give your opinion regarding this presentation and sharing your experience regarding the vasculitis.
I think I must first thank Professor Minhaj and Dr. Haq and the Bangladesh Rheumatology Society for this very kind invitation. It was really a joy to participate. It's always a joy. I've been invited a couple of times previously also, and it's always a pleasure. I must say both the presenters, they did a very excellent job. I think they did a very good literature review also. And they not only did the international literature review, but they did the literature review in this part of the world also. Having said that, in our experience, as with reference to ANCA vasculitis, it is common. We now have our own cohort of more than 300 plus ANCA patients. The commonest is a PR3 positive GPA. And what our publications have done is that previously it was thought that in Asia, it is more of MPO positive GPA or MPO positive Wegener's, which was reported from Japan. Not only MPA, but it was MPO positive GPA. And always it was written that the GPA or Wegener's in Asia is MPO positive GPA, because that was what was reported from Japan. But what we see is more like our Northern European counterparts. It's PR3 positive disease. It's all the phenotypes are same. We have relatively lesser renal involvement as compared to some of the European cohorts with better renal outcomes, especially in GPA. Then GPA is followed by MPA is the next most common, and then eGPA or Church-Crossed is the rarest. So out of 300 odd, I think we only have around 20 odd eGPA or Church-Crossed, and almost 2/3 are GPA. And it is predominantly PR3 positive GPA. I think an excellent presentation was made on ANCA. Couple of comments. One thing is now, as far as ANCA testing is concerned, the international consensus is to only do the third generation ELISAs for PR3 and MPO. And if the first test is negative and you still have a strong clinical possibility, test with a different kit, ELISA kit again. And if both are negative and if you still have a strong suspicion, then only IIF has to be done, and that too in a lab which is standardized to carry out the immunofluorescence ANCA. This is something which is a departure from the previous international ANCA consensus testing to this, I think. Rest all, I think, was beautifully covered. Both the talks were fantastic, amazing. I think well covering the vast topics within the time frame which was given to both the speakers. So I would probably both thank and congratulate both the speakers for job well done.
Thank you, sir. Thank you very much to give us the time, your time and your valuable opinion. Now I would like to request Major Dr. Syed Jamil Abdal sir, consultant, rheumatologist and medicine specialist, Green Lab Center for Research Care and Rheumatic Care and Research, Dhaka. I would like to request to give your valuable opinion regarding the presentation and also your experience in the vasculitis.
Thank you very much, Dr. Shahin Mahmood. At the outset, I would like to express my deep gratitude to Bangladesh Rheumatology Society for inviting me as a panelist. And I'd like to congratulate both the speakers, both Dr. Tania Kabir and Dr. Farzana Shami, for their brilliant presentation, by which we have learned many things. We have enriched our knowledge. And vasculitis is not a very common disease in our day-to-day clinical practice. So we should be vigilant for reaching a diagnosis, while we should also consider the masqueraders as well, especially in the diagnosis of small vessel vasculitis. There are many secondary causes like infections and also drugs. And thank you very much for, again, I invite, express my gratitude to Bangladesh Rheumatology Society.
Thank you, Syed Jamil Abdal sir. Probably Dr. Shamim Ahmed sir is now disconnected from the webinar, I see. So I'd like to request Professor Dr. Mohammad Abu Shahin, sir, Professor, Department of Rheumatology, Bangladesh Sheikh Mujib University, I would like to request to give your valuable opinion regarding the presentation and also your experience in the vascular.
Thank you, Dr. Shahin Mahmood. Respected chairperson of today's session, Professor Syed Atiqul Haq, President Bangladesh Rheumatology Society, who is our venture, and I think we are really blessed to be a student as well as follower of Professor Haq, the great person. The foreign expert, really we are pleased. His presence is definitely enlightened our session, and the organizer, Professor Minhaj Rahim Choudhury sir, Secretary General Bangladesh Rheumatology Society and Chairman Department of Rheumatology, learned panel of expert, so Jamil Abdal, learned participant. Assalamu alaikum. Today's presentation topic is on small vessel vasculitis. Actually, it is a rare disease. Professor Dr. Jamil Abdal already mentioned it is rare, not common, sometimes difficult to diagnose. Once upon a time, it was considered that a fatal disease. Now, vasculitis effectively treated and considered as a chronic condition. Dr. Farzana Shami and Dr. Tania Kabir nicely presented the topic. They tried to cover all the aspects by his presentation and by case scenario. Actually, when a patient presented to us with unexplained comorbidities or complications, more than one organ system that are compatible with vasculitis, particularly when systemic illness are present. We have learned many things from both the speakers, Dr. Tania and Dr. Farzana. They are really genius and exceptionally intelligent. Dr. Tania nicely discussed the pathogenesis, as well as how to develop vasculitis, how causes the cells causes the injury of the vessel wall. And Dr. Farzana brilliantly discuss regarding treatment of cutaneous vasculitis and her experience with more than 5 case scenario. I think, last of all, I think we should diagnose the case timely and properly. And if we provide treatment effectively and earlier, that we can prevent the long-term complication, organ damage, as well as we can save a person, we can save a patient. Thank you very much.
Thank you, Professor Abu Shahin sir. Again, I see probably Professor Mohammad Nazrul sir is disconnected now from this webinar. So I would like to request to Professor Dr. Minhaj Rahim Choudhury, sir, Chairman, Department of Rheumatology, Bangabandhu Sheikh Mujib University, and also Secretary General, Bangladesh Rheumatology Society. I would like to request Professor Minhaj Rahim Choudhury, sir, to give his valuable opinion regarding the presentation and also the experience in the vasculitis.
Mr. Chairperson and learned audiences, it's a pleasure and satisfaction that we have organized this webinar on a very important topic, I must say, small vessel vasculitis. And although we came to know that one of our panel of experts, and I think both of them were telling that it's a rare condition. I think could be like uncommon to rare. If we consider our setting, rheumatology setting, we are getting patients in our private practice, in our hospitals. But definitely if we compare with the others, I mean, I am talking about in our country perspective. We get patients. If we compare with the more common conditions, then definitely very often we do not encounter these patients. But again, I agree with Dr. Jamil that we have to remain very vigilant. Otherwise, we will miss the cases, and the delay in the diagnosis will delay the management, and it will bring lots of problems for the patients in terms of morbidity and even mortality. And today, all the panel of experts, they already told that both the speakers were outstanding, and it's obvious that they worked very hard for preparing their lectures. I am very much impressed. And first speaker, if we look at Dr. Tania Kobir, she focused on ANCA-associated vasculitis. And actually, it's used, Professor Aman Sharma already told, it's used and very difficult to address in 20 to 25 minutes time. But she nicely covered almost all the important portions. And she also focused on an important issue, what Professor Aman Sharma also told, NTPR3, new concepts on NTPR3 and anti-MNO, MPO antibody, and their importances. And the second speaker, Dr. Fazana Shumi, she also talked brilliantly on cutaneous vasculitis. Again, I should say, it's a huge area to cover. She tried to focus on all the important issues again, and I'm very much confident that we all were able to enrich our knowledge from their deliberation. Professor Aman Sharma also shared his experiences, and it contributed a lot. In this session, I am again expressing my gratitude to him for accepting our invitation. We have to remember we encounter patients with small vessel vasculitis in our day-to-day practice, and we must not miss these patients. So we have to, again, I must repeat, we have to remain very cautious. And I just want to share my experience with you, all the audiences, that now I have at least 3 to 4 patients. They first went to a pulmonologist and they were on antitubercular chemotherapy. And then they were eventually diagnosed as vasculitis, especially ANCA-associated vasculitis. So these are the things we need to remember. And so it's a multidisciplinary approach. We have to remember Dr. Tania Kobir, she nicely mentioned in her conclusion, I have noted. And so at the end, I would say we are thankful to our scientific partner, ACI Pharmaceuticals, and media partner, Dr. Stevie, to make this program successful. And with these few words, I'd like to conclude my comments. Thank you, everybody, for participation.
Thank you, Minhaj Rahim Choudhury, sir. now we are near to the end of the session, but the very important comments also remaining here. Our renowned Professor Syed Atiqul sir, President Bangladesh Rheumatology Society and immediate past President APLAR, and founder chairman of the Rheumatology Department of Rheumatology in Bangladesh Sheikh Mujib University, and he is also very experts in the infectious and cutaneous infectious vasculitis. I know with the other topic also. So I would like to request today's chairperson, Professor Syed Atiqul sir, to give his valuable opinion and at last conclude the session. Thank you.
Sir, unmute, please, sir. Sir, unmute yourself.
Okay. Thank you very much. Thank you, Shahin Mahmood, for asking me to give my concluding talks. I would say, only a few words about the academic from the academic arena, because everything is already told. Firstly, regarding the difference between liver-died vasculitis and liver-died vasculopathy and small vessel vasculitis of the skin, there are some clinical points like, skin nodules are linear or angular in case of liver-died vasculitis, not rounded or circular as in vasculitis. And moreover, there are atrophy blanche. These are clinical pointers to liver-died vasculitis. And among the histological features, luminal thrombus is much more common than in true small vessel vasculitis. And also there may be endothelial proliferation. Subintimal hyalinization is quite characteristic of this. And also, there may be fibrinoid necrosis is quite common. In fact, there is angiocentric accumulation of the inflammatory cells, but cells invading the vessel wall is almost never found. With these histological features also, we can differentiate. And another question also arose that, how can we select the time, or how can I do the biopsy of, lesions from two different ages? Actually, lesions appears in crops, but not exactly at 24-hour intervals. So whenever we examine a patient, there will be multiple crops, a mixture. The crops are more often pleomorphic. So, we can find lesions of different ages at the same time. Thus, the appearance of the lesions and also, history from the patients. Patients are often quite intelligent, and patients tell us that, sir, this one appeared 2 days before and this one is fresh. Sometimes patients may also point it out. So it is possible to take, 2 biopsy specimens from, lesions of 2 different ages, one for immunofluorescent microscopy and the other one for light microscopy. It is very much possible. And, I think this one has been hinted by Farjana Shumi, but it should be made clear that, this when actually purpura, petici, these are features of small vessel vasculitis in the skin and also shallow ulcers, but nodules, liver-died reticularis, and and deep ulcer, these are features of medium vessel vasculitis. When there is a small vessel vasculitis, but along with some, medium vessel features, this is more suggestive of ANCA associated. When it is purely immune-mediated, immune complex vasculitis of the skin like cryoglobulic or IgA vasculitis, the lesions, we shall almost never find the evidence of medium vessel vasculitis. But when it is ANCA associated, we may find features, evidence of medium vessel vasculitis. These are, some points that we have to remember. And another point, actually, I was thought of reminding, but now I have forgotten. Okay, I think these are 2 important or 2 important issues that I should point it out. And I would say that actually Tania Kabir and Farjana Shumi, I used to give this lecture when I worked as teacher in the active form. Now I have retired, but now today I have observed that both Farjana Shumi and Tania Kabir, they have greatly outperformed me and they have already, proved that I have become outdated. That is a very good thing. And actually, they have reminded me of the Persian story of Rustam and Sohrab. They have appeared like Rustam to me, and I feel extremely happy. And I congratulate them for their nice and quite elaborate lectures within the short span of time. And also, I would thank the panelists for their very valuable comments, particularly Aman Sharma has greatly enriched us with his experience, with his research findings. Not only, I won't say this is experience, with his research findings, because he has done research with all these aspects of vasculitis, which we could not do because of our workload or many other things. We could not, a lack of organization, we could not do these things. And of course, I forgot, another point. Actually, I have to, echo the voice of Minhaj that, it is true that as a whole, vasculitis are rare conditions, but at least there are two types of small vessel vasculitis, cutaneous small vessel vasculitis, which are very common. One is IgA vasculitis. You can say, I often used to say that, in our country, even the, most, I would say, incompetent doctors working in the remote emergencies of the, our union subcenters, they also will not fail to make two diagnoses correctly. One is IgA vasculitis, though they say henoxyl purpura, and the other is hysterical psychoneurosis, what is currently called conversion disorder. These are not mistaken by any doctor in Bangladesh, because this is, IgA vasculitis is quite common. Its prevalence is quite high. And the other is, what was formerly called hypersensitivity vasculitis of the skin. But now, actually, Chapel Hill has named it leukocytoclastic vasculitis of the skin. Actually, it is a bit confusing, but we have to follow the nomenclature. This one is also quite common, either drug-induced or infective. This is also quite common. Maybe not as common as IgA vasculitis, but that is near. The prevalence may be close to IgA vasculitis. These two are quite common, though the vasculitis which are academically more fascinating, like, we are very fond of talking of, ANCA-associated vasculitis, then hypocomplementemic arterial vasculitis, and, I would say GPA, EGPA, MPA. We like to talk more on these things. These are rare. They are not common, but there are common forms of vasculitis. And I thank, other panelists also. They have enriched, and other, other participants. They have, quite, I would say, tenaciously have, still attending the session up to this end. So I thank them all. And with these few words, actually, I conclude today's session. Thank you very much.
Thank you. So now we can leave, or the moderator?
Sir,
ঠিক আছে, সবাই ভালো থাকো। গুড নাইট। আমরা প্রফেসর সুনীলকে দেখতে পাচ্ছি।
সুনীল মনে হয়
Thank you very much. Okay.